Hey, a quick shout out before we dive into today's episode. Million Podcasts has named Beyond the Mask the #1 anesthesia podcast of 2026. Congrats to Sharon, Jeremy, and everyone behind the scenes making this show happen. And a huge thank you to you for listening and sharing the show.
Welcome to Beyond the Mask. Today's episode is a special one. We're coming to you from Australia, on the ground at the International Federation of Nurse Anesthetists Congress, where clinicians from around the world have gathered to share knowledge, expand perspectives, and push our profession forward. And one of the greatest advantages of being here is the opportunity to explore areas of practice that many of us don't encounter every day. Again, I'm joined by special guest co-host Kevin Chem, who is here with me at IFNA, helping bring these global conversations to you. We're sitting down with Associate Professor Susannah Sherlock to talk about hyperbaric medicine and its interaction and intersection with anesthesia. In this episode, we explore who these patients are, what conditions are being treated, and how hyperbaric therapy plays a critical role in improving outcomes. We also dive into the team-based nature of hyperbaric medicine, the collaboration required across disciplines, and how anesthesia providers fit into that movement. But at the heart of this conversation is something even bigger: quality of life. Because for many patients, especially those dealing with the long-term effects of radiation, early referral and appropriate treatment can make a profound difference in how they live. This is one of those conversations that expands your understanding of what's possible in patient care and where anesthesia knowledge can extend beyond the OR.
CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to Beyond the Mask, innovation and opportunities for CRNAs and advanced practice nurses, with certified financial planner Jeremy Stanley and CRNA Sharon Pierce. Jeremy Stanley has worked with CRNAs for more than 23 years, and Sharon Pierce is a former president of the AANA and the NCANA. Join us as we leave the operating room and learn the latest in the CRNA and advanced practice nurse industries. Beyond the Mask starts in 10, 9, 8, 7.
This is amazing. So, Susannah, I've never this part of medicine. No idea.
Why do you think I picked this out of the lineup?
Can you tell us about your background, what sort of medical professional you are and how you got into this niche sector of medicine?
Yeah, I'm glad you described it that way. It certainly is a niche sector, and a lot of people don't get experience or exposure to it. And that is why it's kind of like the chamber of secrets that, not many people know what we do. So I was very fortunate because in Australia, the model is I'm an anaesthetist by training, so I'm a medical specialist. And during my medical specialty training, we do compulsory intensive care training. And the hospital that I was attached to doing my intensive care training had a hyperbaric chamber in it. And that was in Melbourne at the Alfred Hospital. And looking around the country, practically every quaternary trauma centre, major teaching hospital has a hyperbaric unit attached to it. Canberra is the exception, which is unusual since it's our capital. But I worked at the Alfred. I then moved to Hobart in Tasmania, and I worked as an anaesthetist and hyperbaric specialist there. And then I came to Brisbane when they opened a chamber at their major public facility here. And now I'm actually the medical director of the only private hospital hyperbaric facility that's registered in Australia. I work in public.
People can't see us, but Kevin and I just looked at each other and our eyes are just huge.
It is interesting because unless I fell into it because I was exposed to it and went, oh, this looks interesting. And then I had opportunities by being at hospitals that actually had a unit and I followed the training pathway. I ultimately became an examiner for the specialist exam, and the exam to become a certificate holder in hyperbaric medicine, as a subspecialty of anesthesia, is done by the Anaesthetic College. So I was an examiner for, I think, 5 years. I've retired from that now. But it's a privilege to see so many younger anaesthetists and other specialists. So to become a hyperbaric specialist, you just have to have a subspecialty. Whether you're a surgeon, a radiation oncologist, a GP, you just have to have a fellowship. And once you've done that, you can then get training in an accredited unit for the appropriate amount of time, do all the bits and bobs, the courses, the research projects, all the other things, and then you can sit the exam, which is a traditional exam like any other fellowship type exam. You have a written and then a viva voce examination.
And a what?
A viva voce oral exam.
Say that slowly.
A viva voce, which is...
The voce.
So that's just an oral examination. There's just the British term for oral exam.
Vocal, something about vocalization.
Voice.
Yeah.
Latin for voice.
It's fun.
We're picking that up.
So, viva as in live, voice.
Oh, okay.
Viva voce.
There you
And
go.
it's a bit like this. You sit down with two examiners and they ask you questions, and so long as you look like you have some knowledge and appears safe, then you can subsequently pass that exam.
So oral boards, I think, is what we call them.
Yeah. So how long does it take you? It sounds like our certification process of sorts, subspecialty certification. How long does it take you to get certified in hyperbaric care?
Well, because it comes after all the other things, you've got to take into account your medical training, which for me was 6 years, and then your anaesthetic training, which is another 5 years, and then you have to formally do 2 years as like a registrar in terms of workload and research project. So all up
a long time,
a decade or more post medical graduate.
You get an undergraduate degree too, like in the States?
Yeah, well, I did, but only because I didn't go straight into medicine.
I see.
I did a science degree in physiology major, which was very relevant to hyperbaric, of course, because hyperbaric is pretty much using the science of gas laws to treat patients. So anesthetics is a great fit because, of course, gas laws are a big part of anesthesia training as well, and physiology is. So I've kind of always stayed on that pathway of physiology and using physiological and physics principles to treat patients.
That's amazing. So, I mean, what cases are you treating? Like when we talk about hyperbaric medicine, can you really break down what sort of cases you're seeing with this and how they apply to anesthesia?
Surprisingly, it's not divers. Everyone thinks we treat a lot of divers. So that's the minor area of a clinical hyperbaric unit. We do provide those services, but we don't use them as much as for our general patient workload. Looks like 80% of our patients will have had cancer, will have had cancer treatment, which would have included radiology, radiation treatment. And then subsequently, often years past the radiation, when they've survived their tumour, they then develop signs and symptoms related to radiation damage. And we provide services to 80% of our patient load would be like that. The other patients would be a cohort of acute surgical care, patients who have plastics, flaps that look threatened, that need resuscitating, patients with chronic diabetic foot ulcers because of...
We don't do any of this in the States at all. We just cut their feet off. We start out a toe at a time, and then we just start working our way up.
Yeah, we do a lot of synergy with surgical colleagues. So we would often give advice as to what sort of amputation level would be the best for a patient, looking at the amount of oxygen in their blood, because we do transcutaneous oxygen measurements to look at skin integrity. And we will give hyperbaric support to improve that skin integrity. Because if you can change somebody to a below knee amputation where they would have been an above knee, the disability attached with that is so much higher. So that's one aspect. But obviously to prevent any amputation would be another. So to have a full suite of giving hyperbaric to a diabetic to improve their microvascular circulation after all macrovascular things have been done by the vascular surgeon to improve what they can, and good foot care with podiatry, offloading, debridement, and hyperbaric. So we can do all of those things together and turn what can often look like this is definitely going to be an amputation into a salvageable foot, which has no ulcer at the end of the treatment. But that can take 8 weeks to turn something around.
Only 8 weeks? That
Fairly labour intensive.
I know, but I was thinking it would be longer than that.
Yeah. I think about how many times we just default to amputation where something like this could possibly save or salvage more.
Yeah, and I think that probably the cost-benefit analysis, an amputation can have a whole run-off in terms of other disability, especially in occupational loss of income, years at work that are lost. So if you can prevent it with good care, that would be one thing. But it's still probably a small percentage of our patient load, maybe 10%. And another area that many people do not know that we do is we treat idiopathic sudden sensory hearing loss, which is a big aspect of our work. It's probably 10%, maybe even 15%. And that is ENT referrals for urgent hearing loss. It's idiopathic because we don't know why it happens, but it happens a lot. And once you get into that, once you're working in that domain, you realise how many people it affects. And this is people from teenagers right through to older people where they basically just wake up deaf.
Oh, I don't like that.
Yeah. So if you get the diagnosis right, and we rely upon GPs to be, good GPs will know the difference between sensorineural hearing loss and conductive hearing loss, then that's the key to treating it. Because if you think it's just a conductive hearing loss because the ear is blocked because of an infection, you can lose vital time before in that temporal window when hyperbaric might achieve hearing gain. So we like to see people within 2 weeks of onset. So that means GPs need to be on the game, knowing the difference between conductive and sensorineural. And if they pick it correctly, send them to an ENT surgeon so that they can have an MRI scan to exclude a retrocochlear tumour, which would need to be excluded. And if that's been excluded, they start steroids and they come for hyperbaric. And we have very good outcomes. Probably 80% of the patients that we see in the temporal window that's best within the first 2 weeks would have an improvement in their hearing, either back to normal to the other ear or from a profound hearing loss to a mild hearing loss that's hearing aidable with a hearing aid. Because if you're profound, no amount of hearing aid will be assistant to you because you get such distorted sound if you have to have a really high setting on your hearing aid. You can't hear anything. So we do quite a lot of sudden sensory hearing loss as urgent care.
Now, I'm going to ask a question that may seem stupid to you, but what is it? What does this look like? How long is a patient in the chamber? Describe a chamber. Because honestly, I've never seen one. Have you,
no,
Kevin?
Not in person, no.
And you see them on TV and you're probably, that's probably
not realistic.
So give us basics of this, because I would say that 99% of the people who are listening to this have no clue about it, just like myself. So
there are two sorts of chambers. One is called a monoplace. It's meant for one person to be inside the chamber. And they're the things that people may have seen. I think many people saw the picture of Michael Jackson in their chamber, and it went viral that Michael Jackson sleeps in a hyperbaric chamber.
I remember that.
Yes, well, he didn't, but because Michael Jackson was very open to having weirdness around him.
He was Michael Jackson.
That's right.
Yeah.
So he didn't dispel the myth. But in fact, what happened there was he donated a chamber, a monoplace chamber, to a children's hospital in the States. And as part of the press day, when they were there putting the hyperbaric chamber into the hospital, one of the press said, "Hey, Michael, can you get in there so that we can take a picture?" So he gets in there, they take a picture, and it goes viral. Michael Jackson sleeps in a chamber, which was totally preposterous, but it didn't matter to him. But of course, it's these myths that make people wonder what's going on. A monoplace chamber is a chamber you can put somebody in and you treat them by flooding the chamber with oxygen, and the attendant is outside monitoring.
And how big is it?
It's
People who are claustrophobic, will they have a problem?
It is made generally of perspex, so it's clear. You can see the person inside.
Okay.
But it's a cylinder shape, and it's about the size, sadly, of a coffin. So it's that sort of.
Yeah.
So
Put it that way.
Many people don't like that idea. So most hospital-based ones, which I've been attached to, have what we call multi-place chambers, which are large, big constructions built of steel, a bit like 40-foot shipping containers.
Okay.
Except they're reinforced steel, much stronger because of the reinforcement. So when you're inside, it's a bit like being inside a fuselage of a military plane. That's what it feels like. It's all metal with round windows, perspex windows, very thick windows. Yeah. Lots of rivets. So when you're inside a chamber, that's what it feels like being inside a military aeroplane. And on the outside is normally a big square box. And we have multiple locks. So patients are treated in a group, normally, depending on the size of the chamber, 6 to 12 patients.
So y'all are all just hanging
They're
out
all
together?
sitting there in premium seating with, big soft chairs with big hospital recliners. Yeah. And they have a nurse inside who's the attendant to ensure everybody's okay. And the oxygen is provided by a hood or a mask in order to reduce the risk of fire and explosion, because we're working with oxygen under pressure. So the chamber's flooded with air, and once the chamber is pressurised, then the patients put their oxygen hoods on, because they need to be able to equalise their air. So it's just like being in an aeroplane coming down on descent. You're getting the popping of your ears coming down on descent because the air pressure is increasing from altitude, getting back to Earth. Yeah. In our chamber, we're not going anywhere. We're pushing gas in, and it's pressurising the chamber. And so treatment pressure is about 10 to 18 metres equivalent seawater depth. So we just pump air in until we get to that depth. And then, after everybody's equalised, their hoods go on and they get 100% oxygen. So now they're getting 100% oxygen under pressure. And if you know your alveolar gas equations,
that was 35 years ago. And you have no excuse there, Kevin.
Yeah.
So if you're working, you're at more than one atmosphere and you're getting 100% oxygen. So when you work out the math, you're getting 2,500 millimeters mercury oxygen in your bloodstream instead of 100.
Yeah, that's wild.
Yeah, which normally we'd get when we're breathing 21% minus the CO2 component at 760 millimeters mercury, 1 atmosphere. Yeah. So the math works out that we're getting this extraordinary high amount of oxygen in the bloodstream. And the reason why this works to treat patients with radiation injury, the fundamental issue with radiation is when you get the radiation, the dose goes into tissues which have cancer. And you cannot deliver a toxic dose to a cancer cell without delivering some to the penumbra around it. And this is especially so in areas like the head and neck where there are not many structures, you can't help but go through bone or salivary tissue to get to the oropharynx. Prostate cancer, very common. People are living longer, having better outcomes with treatment, surgical treatments. If you fail that, radiation's added. And if you have that, you cannot help but go through the bladder and then radiation cystitis. And that would be the biggest number of patients we see, men, prostate cancer, who ultimately come with radiation cystitis.
You'll have to remember this for your older age there, Kevin.
Something to look forward to. Wow.
Yeah, 80% of men over 80.
Oh my gosh.
Yeah, so it's kind of like, we have these patients in the chamber, they're breathing this really high oxygen dose. And what happens at the body level is you've got a really high level of oxygen in tissues that are normal and a low level of oxygen in tissues that are not normal because of microvascular damage, because of the radiation that causes fibrosis, hypoxia, and scarring. So you've got this bladder that's all scarred and fibrosed, and that doesn't have a good blood supply. The body recognises the difference and the gradient between good tissue and bad tissue, just like it does when it recognises a cut. When you have a cut, you have normal tissue around it. In the base of the cut, it doesn't have good oxygen supply because you just cut vessels. and the body repairs because it recognizes the difference. So all we're doing is mimicking normal healing, which is massive blood supply in a normal tissue. The body recognizes the low blood supply in the abnormal tissue, and then we get bone marrow cells coming out from the bone marrow. There's stem cells that come out, they start neovascularization process, and that takes a few weeks. So the common treatment is 2 hours a day of treatment over 6 weeks. Normally we start to see symptom resolution after 4 weeks, and we continue, somebody's responding to 6 weeks. But it's to prevent people going on to have a cystectomy or, continued bladder washouts, re-irrigation, superbute catheters, that sort of thing. So if we can turn all that around by getting the bladder revascularized, and that's basically how it works. And it works for head and neck cancer things as well. And I think the important thing to note on that is that when we get the healing happening, is recurrence of tumour rate is no different for those patients who received hyperbaric to those who did not. So we don't ever worry about tumour recurrence rate because we've got heaps of evidence to show there is no difference. But obviously patients worry, if I'm having this oxygen, could my tumour come back? And the answer to that is no.
How well do you really know the history of your profession? Go beyond the textbook and hear the real stories, the pioneers, the battles, the breakthroughs, and the voices who shaped nurse anesthesia into what it is today. Beyond the Mask podcast, the historical series, brings it all together. Remastered episodes, archival photos, and exclusive historical content, all in one place, commercial-free and on demand. And it's growing. New historical episodes and interviews will be added over time. Lifetime access is only $149. Schools and educational programs, ask about special group pricing. Hear the legacy that built nurse anesthesia. Visit beyondthemaskpodcast.com and click the CRNA History Course button, or check the show description for a direct link.
You're answering this question we have where it's like anesthesia, hyperbaric medicine, but you're talking about gas laws and all of this. Have you seen them complement each other in other ways as well?
Oh, absolutely, because every hyperbaric chamber in Australia, these hospital ones, has to be able to provide critical care services. So intubated patients, ventilated patients. There's even been a couple of ECMO patients. One of them was actually for a US Marine that went down in an Osprey in a training exercise off Darwin in 2023. And that Marine was lucky to survive, had a cardiac arrest on site, I believe. He was flown to Darwin and then flown subsequently to the Alfred where I'd trained. And the Alfred did some pretty heroic measures. They had him on ECMO. And during his inpatient stay in the intensive care unit on ECMO, he sadly developed a fungal infection of his head. And so he required hyperbaric because we treat bubbles, we treat infection, and we treat hypoxia. They're the three main things that hyperbaric treats. And in this gentleman's case, he had a fungal infection that required treatment, but he was on ECMO. So they had to put in a whole team, intensivists, hyperbaric physicians, anaesthetists, all to run a patient going into a chamber with all this equipment to have his ECMO whilst having hyperbaric. It was and they've actually done a pediatric patient as well with necrotizing from a preterm.
So you're providing sedation or anesthesia for
so
them also?
Not personally me. The clever team at the Alfred Hospital did this, and they're the only team in Australia that have done now an adult, a military man, a US Marine, and a pediatric patient. But they're first in Australia to run such complex cases. But, I myself have run intubated, anaesthetised patients and continued in my role as the anaesthetist, keeping someone sedated whilst they've been treated when they've had gas embolism from diving injuries and gas embolism from iatrogenic injury from laparoscopic surgery, which obviously if the port goes in the wrong spot, you can have massive gas embolism, and we treat that because that's no different to like a diving gas embolism.
So how much is hyperbaric treatment?
It's free in Australia because we have Medicare.
Next question.
Next question. So it's free, even in the private sector. So if you have private health insurance in Australia, you could come to us and we don't charge any gap payment or anything else. It's all paid for by Medicare and your insurer. If you're a public patient, it's paid by Medicare and the hospital purse, the taxpayer. So no one pays
the hospital purse, i.e. the taxpayer.
Yeah. But there is a difference, of course, between what I'm talking about, multi-chamber. Multi-locks means there's other locks attached for it, so that you might have 2 or 3 locks all in concession. So you can have all your patients in one. You can have a medical entry in the event that a doctor needs to go in. Yeah. And you can have another lock for an urgent case that comes in whilst these guys are at pressure. So, there are multiple locks that you can have at different pressures. Some people consider mild hyperbaric, which is a completely different beast, which is often purported to treat all sorts of things from insomnia to cancer to ADHD, autism. Now, sadly, those are unregulated. In Australia, they're not paid by the taxpayer because there's no evidence to suggest that they should be. And so people who are desperate often may go that pathway. And I'm always happy to consult on patients, even when I know I'm not going to treat them, to allow them to understand why they shouldn't go that pathway. Because if you're paying for care that's not going to work, where there's no evidence behind it, and you're also putting your child potentially at risk, that's a bad thing. And people need to know that. And the average GP's never had any teaching in hyperbaric, so they don't know the difference between the hyperbaric unit that's advertising at the wellness centre or the gym compared to the hyperbaric unit that is a proper critical care facility that can provide intensive care medicine. Yeah. And there is obviously a big difference. So I will see patients even when I know I'm not going to treat them, so I can advise them, because I think that's part of our role, to make sure people stay safe. And in the US, there's been 2 deaths just in 2025, both of them because of monoplace chambers where they were run in unregulated centres by people that were not qualified to do such a thing, and ended in death. One was a child, 8 years old, with ADHD. It's before the courts in the US at the moment. I think there's manslaughter charges being brought against the owners. And there was a self-described doctor who was a sports physician, but not a doctor, who was running his own centre, who was treating himself at night in a monoplace when a fire.
That's not the way you want to go.
So the child died in a fire in 2025.
Well, that's not.
And the doctor also died in a fire. Both of those are before the courts at the moment. And 2 years before that, or a couple of years before that, there was another child death in the US, same thing, fire, but the grandparent was in the chamber with the child at the same time. So there was 2 deaths, the grandmother and the child. And again, it was an off-label autism with no evidence to support its use.
It's terrifying.
So these are things to consider when you go for hyperbaric, what you're actually getting, who's providing the treatment, and whether it's in a regulated setting. Because in a regulated setting, we have maintenance protocols, high hospital standards, and regular safety procedures. We just did every 6 months we do safety drills on a weekend with all of our staff, because I can't provide care without specialised nurses and specialised technicians running the chamber. So we do all of our drills together as a team, and we did it last Saturday, and we do it every 6 months to make sure that all the team know what to do in the event of an emergency, especially a fire.
Well, we have both learned a lot today.
Actually a lot. Yes, this was great.
We want to thank you for joining us. I know that our listeners are going to enjoy listening to this, because I know of no nurse anesthetist in the United States that does this, but it's a lot to think about, honestly. So we want to appreciate everything that you're doing, and thank you for sharing this knowledge with us.
It's been a pleasure, and I'm very happy that you invited me to come and speak about some of the differences that we have across the ocean in terms of practice, and it's been a pleasure to share it with you.
Thank you for tuning in to Beyond the Mask. If you enjoy the show and want to help us grow, the best way to support us is simple. Leave a review on your favorite podcast platform, share the show on social media, and tell your friends. Your word of mouth is what keeps us going strong. We're proud to consistently rank in the top 50 medical podcasts nationwide and to be #1 in the CRNA community. All thanks to listeners like you. Your support helps us stay there, and we couldn't do it without you. We'll see you on the next Beyond the Mask.
Are you looking to transition into independent practice? AANA and Beyond the Mask are here to help you thrive as your own boss. Visit the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management tailored specifically for 1099 CRNAs. Lean into the feeling of freedom and embrace the opportunity to be your own boss. Enroll now and gain the knowledge you need to navigate the business side of independent practice. Plus, enjoy a special 20% discount using the code BEYOND1099 at checkout. Visit aana.com/1099 to learn more and start building the future you want. The 1099 CRNA Institute. Thrive as your own boss.